Hello, my name is Dr. John Connolly. I'm the Chief Science Officer of VoxNeuro and a professor at McMaster University. So welcome to the VoxNeuro-sponsored Brain Injury Canada webinar. I'll be speaking initially, and I have the opportunity to introduce two of my colleagues who will be speaking after me. They are Dr. Boshra, who will be talking about the future, and Dr. Kyle Ruiter, who'll be talking about the present. And partially because I'm the oldest one, I'll be talking about the past and when we started this work. So, and that's the slide that says what I just said. So the past, I'll be saying where all this work began, which was in 1991. Dr. Boshra will be talking about data-driven new methods of data analysis, so the future. And Dr. Ruiter will be talking about how this technology helps people today. And that's the present. So where it all began. It began in 1991 when we tested a patient who was declared to be diagnosed to be in a vegetative state using a method called consensus diagnosis, which I'll mention again later. But I'm going to talk about a more recent patient that we tested in Hamilton. And also I should point out that I have Rohan Pace's permission to do this, as well as Paula Pace, his wife. So I'll talk about the patient story to give you an idea of what we do, the need for objective measures, critical point, the choice of measures and why we choose those particular measures, and then the idea of adapting traditional neuropsychological batteries to do the neuroimaging and the neurorecording that we do. Then, like I said, Dr. Boshra will cover past and current research, the use of artificial intelligence and machine learning to guide research, experimentation, and especially analysis. And then he'll talk about the power of data, the all power of data. Dr. Ruiter will talk about the applications of VoxNeuro's technology into clinical practice today, how this technology helps you, helps clinicians, and also who can this technology help, what types of patients and what types of clinicians. So the past and where all this began. So briefly, we started this work in 1991 with a very seriously injured young man, and we found that we could use electroencephalography and a derived measure called event-related potentials to look at his brain function. He couldn't respond. He didn't have to respond verbally or with his gestures or anything else. He couldn't do anything. He was in a apparent vegetative state. And we tested him, and it was successful to demonstrate that these measures would work. And now I'll explain using Rohan Pace how they work. Rohan, you can see here during rehab about a year ago. Rohan was 46 years old when he sustained a traumatic brain injury due to a car-bicycle collision. He was riding his bike along with a group of others in what's called a peloton, and he was the only person hit by a car, and he was thrown 30 meters. He was resuscitated at the site when the paramedics arrived. He had no vital signs, but they got him going again. And he was then brought to a hospital, and he was diagnosed as being in a coma. Later, when he did emerge from that coma, he was diagnosed as being in a vegetative state. And that is a complicated diagnosis, but basically what it means is the person is no longer in a coma. Their eyes are open. They do respond to a couple of things, possibly, but not very much, but they are no longer in a coma. And he was diagnosed using a test called the Rancho-Los test by a very skilled and very talented and internationally known neurologist named Dr. Jane Gillette. She knew what she was doing, and she used a very good test called the Rancho-Los test to assess his behavioral symptoms. She diagnosed him as being in a vegetative state. The issue is when we did our event-related brain potential work, he was not. He showed a range of mental functions cognitive functions as evidenced by his event-related brain potentials, or EEG, he showed those responses in so robustly that there was no question that he was not in a vegetative state. So that's why behavioral measures are not sufficient. In terms of empirical work on vegetative state, this slide shows you some work by, for example, Caroline Schnackes in 2009, demonstrating, and you can see there are papers below her, she was replicating people, and then she was replicated herself by a group in 2017, demonstrating that the error rates using what's called consensus diagnosis, that's where several neurologists might gather around a patient and look at the patient and judge, well, that looks like vegetative state, that type of diagnosis is wrong up to 43% of the time. And the best it does is 36% error rates. So even with a standardized test like the Coma Recovery Scale, the revised version, that's that acronym you see there, the CRSR, a very, very good behavioral test, even that makes 36% error rates. So there is a real problem with behavioral assessment of these patients. It is not safe to do that. And also, I think what I will point out is that if someone you know, someone in your family or just someone you know, or you should tell your family, if God forbid this should happen to you, that these sorts of tests, behavioral tests, are not accurate enough to give the physicians and the family a good idea of what state you're in. You need to have other types of measures taken. And I'd say right now the literature is, the scientific literature is that EEG, and in particular event-related brain potentials, are the best method available. So, covered that slide. I will now just move on to this. The question determines the technology. What does that mean? It means that the clinician's question or the scientist's question determines what technology they should use to look at your brain. If I care in particular about brain structural changes, then I would use magnetic resonance imaging. It's the best method out there. And what it revealed in Rohan, for example, was that he had sustained a cortical and subcortical hemorrhage with a left-sided focus. He had frontoparietal involvement, so many parts of his brain, and he had brain herniation. This was not good, and we saw this all with the magnetic resonance imaging. It gives structural pictures that are absolutely accurate. If we wanted to look at function, which we did, we looked at EEG and a derived measure from EEG. So this is not standard clinical EEG. It's a special type of EEG. We used event-related potentials, and these are your brain's response to a stimulus within a particular context, and we can see what your brain is doing. So what this reveals in anyone, if they're functioning, is it'll reveal language processing ability. And what we demonstrated was by showing that Rohan displayed a range of activities, including the most sophisticated thing that really we can do as humans is comprehend speech. He showed wonderful responses. His brain was absolutely accurate and active, despite not appearing to be so. He just sat there in the chair and didn't do anything at that point. As you can see, it's a lot different now. But these diagnostic issues matter, because if the diagnosis is vegetative state, then you may go to a palliative care place and receive triage treatment, effectively no treatment, palliative care. If you are diagnosed as being not in a vegetative state, but possibly in a locked-in state, then you will get treatment, as Rohan did. And this resulted in our assessment of Rohan as in terms of showing a particular brain response, indicating he could comprehend sentences that made sense and did not make sense, amongst other things, resulted in Dr. Gillette moving him from the step-down clinic to a different setup so he could receive therapy. And that therapy he responded to. And so what happened with him was that in terms of, and this is a picture of Rohan before his accident riding his bike. And above him is brain activity on 3 different occasions, thus the 3 lines of different colors. And you can see where the arrow is, that is the language comprehension task. And you can see that even the first time we tested him, and then on successive occasions, he showed that response robustly. So it really did indicate that that he was processing language, and actually he then began to speak himself, or actually he began singing during someone's birthday. He started singing Happy Birthday with other people, and that happened about 2 months after verification. The verification you see just above him on that squiggly line, which are the event-related brain potentials. It was about 2 months after we verified that he could comprehend. He then started speaking. And his improvement has continued for over 10 years. And that's an important point in terms of what the expectations might be. Oftentimes it's like you'll see people say that people recover from brain injury and they have about a year or maybe even 2 years, and then pretty much they've topped out. That is not always the case. So really, I think the message here, and I will say, as the last bullet point says, as of 2018, he's continuing his rehab plan and he's learning to walk again. And that was the first photo I showed you of Rohan. He's still in a harness, but he is walking. And I think the message here is, if you or anyone in your family or anyone you know sustains a serious brain injury, it's worth finding out, how are they going to assess that person? She or he may appear to be in a vegetative state. They may not be. So these responses are easily obtained, and they really have other characteristics, which I'm about to go into. So the other thing about EEG and these event-related potentials is that they're a point-of-care tool. You can do assessment at the bedside. That's what that means. You don't have to go to a particular facility or a particular location. The equipment can come to you. So the assessment, the things it does is it provides a differentiation of functional symptoms. For example, a patient may have memory problems, but they can comprehend speech, but their memory is problematic. Memory and speech comprehension may be fine, but their ability to pay attention reliably is a problem. It can measure all these different things. It can also measure change over time. That may happen naturally, so a natural recovery. Also, it is very sensitive, these measures, especially these ERP things. They can really track responses to therapeutic intervention. These measures are objective, quantitative, replicable. In other words, we can see them again and again, and they're clinically relevant because these are the symptoms we're assessing. When I say they're objective, that's in contrast to, for example, consensus diagnosis, where physicians or psychologists may look at a patient and think, that looks to me like it's vegetative state. That's a judgment. Even if the person themselves were able to respond, they may think, I'm pretty good, I'm not in that bad a shape. That's a judgment. It's subjective judgment. It's an opinion. Our measures are not opinion, they're objective. It's what your brain is doing. They're quantitative. We can measure them, give them numbers. We can see them again and again. And also they're looking at clinically relevant symptomatology. Also, what we're doing is moving past the problematic diagnostic issues and going direct to measure the symptoms and then measure them over time. So what are ERPs? Now, I'll just cover this at a very top level, but they are brain responses within a particular context to discrete stimuli. In other words, what I mean by discrete stimuli are tones, flashes of light, or stimuli like sentences, entire sentences, not just tones. And they might be also not just flashes of light, but geometric shapes that require you to really concentrate on something and pay attention. And I think what you can see here in this list is a list of some of the things that we look at. And they range from just basic perceptual processing, as in that N1, to parts of automatic attention. That's attention that you don't even really know you're doing it, but you're doing it. And then N2B, executive function. This is something that is often problematic in somebody who has been brain injured, whether it's a serious brain injury or something called mild traumatic brain injury, a concussion. Executive function requires you to summon together attention, memory, language possibly, to do things like even just planning to go to the grocery store. You have to remember you need to because you need food. You have to remember how to get there. You should not just walk out of the house. You might get in your automobile to carry all the groceries back. That's executive function. It's one of the things that suffers frequently in response to brain injury. Then different types of attention and memory and concentration. And then finally, that slide I showed you of Rohan and that response at the end, language processing. I should also point out, these are not new and novel techniques in those senses. The most recently discovered waveform that we're talking about here is in fact the N400, and that was about language comprehension. That was discovered in 1980, a long time ago. All the others are actually older. So when I say that we've adapted traditional neuropsychological assessments so we can record ERPs or brain responses to the target items in them, what am I talking about there? Well, an example of that is something called the Continuous Visual Memory Test, the CVMT. And this is a series of black and white shapes, some of which repeat up to 6 times. You can see them on the right-hand side. It's also designed so you can't get verbal ideas of what you can't use your memory to try to figure them out. You really do need to just do basic visual processing. And then what you have to do is indicate whether the shape is repeating or not. Now, one of the things I will mention here is that we can get all of these responses even if you're not able to indicate whether the shape is repeating or not. We just tell you the instruction. Don't forget, we've been doing this with patients who are in vegetative state. Turns out they're not. We just give them the instruction. They may not make any response, but they don't need to. Even our so-called control samples, they don't need to make the response. We can see the brain make the response, and that's where the big advantage of these methods exist. So, and what you can see on the left between the dotted line and the solid line is that the solid line is reflecting a memory effect. That's when someone recognizes that they saw that geometric shape before. They show that response. That's a clear marker of visual memory. The next test is a blend of visual processing and then recognizing a word that does or does not accurately describe a picture. So it's a series of black and white pictures presented individually, like the school bus that you see there. And then a little bit after the picture onset, the person in the test, and the Rohan did this test very, very well, will hear the word bus, which is accurate, or hear the word cat, which is very inaccurate. The big green line, the big response there that you can see, that is what happens in your brain when the picture and the word that describes it don't match. And that response is very, very robust. And what you can see is those 3 waveforms. You might think, well, the person was getting worse. Actually, no, those are different levels of vocabulary difficulty. It's a way to make sure that when we get to words that are really tough in English, we wouldn't expect many people to know them. And that's what happens at that level 3. And what happens? That response goes away because people don't know what that word is and what that picture was about. So it demonstrates that when you show that first response in level 1, you really are comprehending what's going on. And Rohan, again, did very well in that test. And that ended up getting him treatment. So that's what the past is. And now I'm happy to introduce Dr. Robert Boshra. We'll talk about the future and data-driven phenomena.
I am Robert Boshra. I'm going to be walking you through the future data-driven direction, where things can go, especially when it comes with brain data and brain health in general. So just to give a general overview, we want to take a look at things that have been done and try to look at the near future and how things are changing in this particular way, and focusing a little bit more on how we can distill our knowledge and use data that are incoming on a daily basis to make our understanding of the brain and brain health a lot more sophisticated. So referring back to what Dr. John Connolly was just talking about, and about the difference between behavior and neurophysiology, and how they don't always say the same thing, and how behavior can sometimes be quite misleading. So one of the problems about using neurophysiology every single time is the fact that you are not able in a clinical setting to have a neurophysiologist always on hand and that is actively looking and actively analyzing a patient's data as it comes through off of somebody in coma. So this is exactly what a group out of McMaster, led by Dr. John Connolly, have worked on. And they captured data from people in coma, and they try to look at how can machine learning help make that detection of the ERP more automated and thus easier and more practical. So if you take a look at this figure, you are able to see two different blocks. So people in coma, as John has mentioned, they can exhibit the mismatched negativity response. They can show it one hour and then it disappears right after. So you need to be able to capture it in that very sporadic point in time where it does show up. And that's exactly what they have done. They developed a machine learning algorithm that can detect those mismatched negativities on the fly. So this was very promising results. These were promising results, and it really spiraled into a full-fledged study that got funding just a couple of years ago. And there is a larger group at McMaster University right now that are collaborating with Hamilton Health Sciences and trying to develop that particular tool that you can just put beside a patient, connected to the patient's EEG, and it will tell you whether somebody is exhibiting a mismatch or not. So moving on to more mild traumatic brain injury. And just as everybody knows, mild traumatic brain injury or concussion they're a different beast, and they convey themselves differently across different people. EEG in general has been explored quite a bit in the literature when it comes to targeting concussion. But for the longest time, it was just using resting state. So just putting an EEG cap on and just looking how the brain is responding. So it wasn't exactly brain responses, it's just brain at rest, which isn't able to detect the effects of concussion beyond, let's say, 6 months to a year after the concussive event has happened. So following that, a large group of researchers all around the globe, and particularly our group at McMaster University, have started looking at event-related potentials and how they get affected during concussion. So in this particular study, we looked at retired Canadian Football League athletes decades after they have had their last concussion, and we're able to find very distinct differences very long time after they were concussed. And if you look at this figure right here, you don't really need to know a lot about ERPs, but just looking at the two figures, and especially where the blue arrows are pointing, these amplitudes are quite smaller. I mean, this is across the entire group of all of athletes. So all of the athletes are on the right side and all of the controls are on the left side. But even visually, you can tell that there's a difference, which means that there is a cognitive deficit there somewhere. So overall, this study established the fact that there is a difference that should be looked at, and that difference isn't really observable if you strictly look at symptomatology. There were definitely cases when people on the single subject level did not really show smaller responses, but according to their symptoms, they were not doing good at all. And vice versa, if you flip that to the other side, there were people that were saying that they're absolutely fine, but their brain signals were not okay at all. So in summary, this was a group level analysis. This was a group level study. And where we wanted to go after that is to look at the subject level. How does one person look like, and how can we help the clinician identify that effect on a single patient. So in the next study, we did exactly that. And we used machine learning to look at that exact same data set and look at, instead of how do the groups compare, retired athletes versus controls, and look at how a particular patient is doing and how their responses are doing. So in using the machine learning algorithm on top of that, and we used expert knowledge, so authors on the paper, we pooled different features, different places where we should look at and where we should lead the machine learning algorithm to look at. And in doing so, we were actually able to get quite substantial accuracy. We were able to correctly classify 4 out of 5 patients, whether they were controls or concussed. And again, this is retired athletes versus controls. And in addition to that, we were also able to investigate how does that learned model reach that conclusion. And in doing so, it feeds into that feedback loop of me as an expert, I tell the machine learning what to do, but then the machine learning algorithm tells me exactly how it did it. And we can identify whether it agrees with the expert knowledge or not. So now, this was just a glimpse on where things are going with concussion research and how we can tell the differences on a single subject level. But then we wanted to push that a little bit further. And instead of the EEG expert telling the machine what exactly to look forward to, we actually expanded that to where the machine learning algorithm does it from the beginning to the end, from an end-to-end sort of procedure. And it was quite successful. I believe it was 85% accuracy in correctly distinguishing which group that particular person belonged to. So it's definitely a new technology. It's definitely in the works, and it will take a couple of iterations in order to refine and make sure that it generalizes to the entire population. But it's definitely going there and in picking up speed in a good way. Also, in the future, we want to make sure that we are able to use more refined machine learning algorithms to make it more accurate, to control for different comorbidities, to understand how things interact. So with things like depression or psychoactive medication, and trying to disentangle that a little bit. And ultimately, when it comes to concussion and treatment and helping those that have been afflicted by it, we want to understand how do we optimize treatments? How do we optimize the time to get back to school or to get back to work using those neurophysiological measures? And in doing that, we will be able to understand a lot more about post-concussive syndrome and symptom resurgence in athletes that have been getting hit for a living, basically. And with that, I'm going to pass forward to what is taking place in the clinic today.
Hi, everyone. Welcome to this webinar. Today, I'm going to be talking about how VoxNeuro's technology and cognitive health assessments can help you today. So the first thing I'm going to start off with is, who can this technology help? Of course, the reason I'm speaking to you today is the fact that we can help those who have suffered from a traumatic brain injury, whether on the more mild traumatic brain injury side, such as concussion, or more significant brain injuries as well, such as stroke. This includes, but what's important to know is that our technology is not exclusive to brain injury survivors. In fact, we can measure just general cognitive function for aging populations, for younger populations. So if we want to look, in adolescents, or we want to look at seniors, see the different, how cognitive function changes over time within an individual's lifetime. We can also test and assess those with neurodegenerative diseases such as Alzheimer's and dementia, etc. We can also measure and test those with cerebral palsy, those suffering from stroke, nonverbal autism, as well as mental health. So specifically, we can measure 5 different cognitive functions, and these are all crucial to anyone suffering from any of the above list that I mentioned here. So how can this technology help you today? So what we do at VoxNeuro is we apply event-related potentials, or ERPs, which Dr. Connolly alluded to earlier, into clinical practice. And these ERPs, I mean, it's just a fancy science word, but really all they are brain responses to specific stimuli. Specifically, they are the amount of electrical activity your brain produces when a stimulus is presented to you. This stimulus could be, a dog barking, it could be any kind of tone, sound, beep, or it could be a visual stimulus such as a picture, etc. So how we measure these brain responses, these ERPs, is twofold. We look at response strength and we look at response time. Now, response strength is quite literally the amount of electrical activity produced in your brain to a specific stimulus being presented to you. So this is really a direct reflection, depending on the task or test that is administered to you, but it's a direct reflection of the ability of your brain to perform a cognitive function. So you can really think of it as how well your brain is performing a cognitive function. Now, the second domain that we measure your cognitive function by is response time. So this is effectively your brain's information processing ability. So really, this is how quickly you can perform that cognitive function. So you can think of it very simply as, in terms of response strength, it's how well you perform the cognitive function, and response time is just how quickly you can measure that cognitive function. So I'm going to dive in just a little bit into the types of cognitive functions that we measure today, and how this can help you, and how this information is critical to helping you on the path to recovery and helping get to your rehabilitation goals. So if you look at the screen here, this is a graphical representation. This is what will be sent to your healthcare provider. And this shows you the different types of cognitive functions that we measure and where they fall relative to, quote unquote, a healthy brain. Somebody who has not sustained a traumatic brain injury or any other type of neurological deficit in their lifetime. So let's first dive into the types of cognitive functions that we measure. We have two different types of attention. We have automatic attention and reactive attention. And then we also measure concentration, working memory, and executive function. Just quickly, to tease apart or to differentiate the two different types of attention, they really are opposing types of attention. Automatic attention is your brain's ability to interpret environmental stimuli around you that you are not actively or consciously paying attention to. This could be the wind blowing through the vents of the AC while you're listening to me. Your brain will always pick up that sound. However, when you are actively paying attention to me, you are not actively paying attention to that sound of the air flowing through the vents, but your brain always picks up that information. So automatic attention is your brain's ability to pick up that stimulus and other environmental stimuli while you are focused on another task at hand. Now, reactive attention is the exact opposite. It's your brain's ability to react to a stimulus being presented to you. This could be, again, this could be a door closing, a tone, a beep, anything like that. It's when your brain is actively paying attention and reacting to the stimulus at hand. So just quickly, in terms of this graph, we have numbers on the graph. This is how we quantify the objective data that we've collected from your brain. And it's split into three different categories. If you see a score less than 25, this shows a deficiency. A score from 25 to 75 shows a moderate deficiency, and anything above 75 shows that you are healthy or in a normal healthy range. And the reason we are able to do this is because these percentiles, these numbers presented here on the screen, are relative to a healthy normative database of over 800 participants, ranging from the ages of 12 to 90. So whatever your age is, your brain responses will be measured against somebody, or a group, I should say, of individuals within that age range. So we know exactly where your cognitive function falls relative to your age range. And the last thing I really want to focus on and point out here is that the ability to look at all the different types of cognitive functions here, we can then tell you which ones show a deficiency and which ones do not show a deficiency. And of course, this will help with the rehabilitation process, which I'll get into in just a moment. The last thing I want to mention here is the base functions checklist. We have auditory processing, visual processing, information processing, which, as I mentioned before, information processing is equivalent to response time, which is on the left-hand side of the graph. So it's important for you to know that, for instance, in this case, that executive function, that person's information processing is fine for that specific cognitive domain. However, the other four cognitive domains do show a deficiency. So we make sure we check off that information processing does have a deficiency so that you know to work on that specific type of processing through your therapy and treatment. And then we also measure language comprehension as well. And from there, this is important to know for those patients who are non-communicative. So for instance, it may be somebody had a stroke and they're unable to verbally express that they understand you. The test that is run in our cognitive health assessment is able to determine whether that individual is capable of actually understanding the language or understand what you are saying to them. So this is obviously very crucial in terms of non-communicative patients, and it's very helpful for the families who are trying to communicate with them and the rehabilitation specialists working with them. So I'm going to move forward from this slide and talk about the usefulness of VoxNeuro's cognitive health assessments in terms of informing rehab. So I touched upon it a little bit earlier. So just to dive a little bit deeper, so the first thing I want to highlight is that there is no baseline required. Often cognitive assessments require a baseline, meaning they need a first assessment and they can't measure the change until the second assessment. Due to the fact that we have a very large normative database of over 800 participants, we do not need a baseline because we already know what the average healthy normal quote unquote brain for your age range is. So as a result, we can just put your brain responses next to a group of individuals in your age range, and we know where your brain function falls relative to that age range, which is great. However, that is not to be said that we can't also measure your cognitive function over time, which I'll get into in just a moment. So second here is what rehabilitation methods should be used. So because we give 5 different cognitive domains of assessment and the results of them, we can, or I should say clinicians are able to know what specific cognitive deficits are showing, which ones are not. So for instance, if someone shows, really, really poor working memory results, however, their attention results are perfectly normal, then the cognitive rehabilitation specialist, and of course you, the patient, will know that, okay, I need to work on working memory. So the clinician will then turn around and get you working on working memory therapy methods. So this really helps to streamline the process and kind of takes away that trial and error phase that is typical in rehabilitation. So I'm sure many of you have gone through this, where you go in to a rehabilitation therapist, excuse me, and at the beginning they're trying to figure out, okay, where are the deficits? Okay, how can we optimize treatment, etc. This eliminates that trial and error phase. So you take this test. We now know where these specific cognitive deficits are. Now the clinician knows, and they can start to work with you right away on those specific cognitive deficit areas and get you back on the road to recovery quicker. And of course, again, because we know where healthy normative range is, and we can measure it over time, we know when you can get back to, when an individual gets back to that normal range, gets back to, and can go back to work, for instance, and go back to play, etc. And lastly, the thing I just want to touch upon on this slide is which methods are producing the best results. So as we move forward, you'll be able to actually help pay it forward in the sense that the method that is used for you, that netted out, let's say, for instance, the best results, you had really great recovery, it was really helpful. Now the next person who comes into the office of the therapist and needs rehabilitation treatment, they can start at that place, based, of course, on their cognitive profile, as everyone's cognitive profile will be slightly different. However, they'll be able to know which methods produce the best outcomes and the best results. So moving forward, we'll be able to really streamline the rehabilitation timeline and help get help to others sooner and quicker and get people back to health faster. So again, I kind of touched upon this a couple times, but here on my last slide, I'm just talking about how we can track cognitive function. So yes, we do not need to have a baseline. You can be tested anytime after your injury. It does not have to be immediately after, but it's really a measurement. The first test is a measurement of where your cognitive function is on that day. As we move forward, and as you move forward through your rehabilitation, you'll be able to, or we will be able to show you your cognitive improvement through those rehabilitation efforts. Now, let's say, through the first 3 months of rehab, you're not feeling you have any, seen any improvement, you're a little bit disappointed in that regard, we can test you again, and then we can objectively identify, okay, you know what, we're not seeing any improvement. So this then tells you and your therapist that, we should not be doing this method of treatment anymore. Let's try a different method of treatment. So not only is it going to tell you exactly where your cognitive function is today and measure it over time, but we are able to notify or inform your rehab in such a way that, if a certain type of rehab isn't working, then let's try a new one. And of course, down the road with this, which I'm sure Dr. Boshra talked about a little bit, is that we will be able to, eventually tell you, the patient, what types of rehab work best based on your cognitive profile. So that's moving forward. But today, we can help to inform your rehab, we can help tailor your rehab, and we can help you with, knowing exactly where your cognitive function is today. Again, if you have any questions regarding this, regarding our assessment, please feel free to email me. You can email me directly at Kyle, Kyle, at VoxNeuro.com. And VoxNeuro is VoxNeuro. I'm very happy to answer any of your questions. They can be as specific or as vague as you like. And I will leave it at that. And thank you very much for your time.
Thank you for watching the Breakthrough in Neurotechnology webinar, presented by VoxNeuro, a corporate sponsor of Brain Injury Canada. If you have any questions about the webinar, email info@voxneuro.com. For more information about the services VoxNeuro provides, visit www.voxneuro.com. If you'd like to learn more about acquired brain injury and the work done by Brain Injury Canada, visit www.braininjurycanada.ca.